Good morning. I was asked to speak on Fasanella Servat procedure, which is not a very popular or a very commonly performed procedure, so to say. There are a host of surgeries for ptosis, and this is just the list. Now, whenever you have a patient with mild ptosis and good levator action, ptosis of about 1.5 2 millimeter or 2.5 millimeter, with levator action of about 10 12 millimeter, irrespective of its etiology, there are a couple of preferred approaches. The first step that you would take in such a patient would be to do a phenylephrine test or an epreclonidine test, assess if it is positive, and if it is positive, you can do transconjunctival approach mullerectomy. But then even if it is negative, you can do mullerectomy and get away with it, and there are studies which show that mullerectomy is effective even in patients who are phenylephrine test negative. But as an alternative to that, we have Fasanella Servat procedure, which is an age-old procedure described in 1961, that long. It was described using hemostats initially, where the tarsus or the lid would be everted and the tarsus that is to be excised would be clamped with two hemostats from either sides, curved hemostats, and then whatever that is to be excised would be excised with the hemostats in position. Hemostats are used only to minimize bleeding and also to make sure that the tarsus remains folded. But the problem with that procedure was the notch that would be created because two ends of the hemostat would not meet with the curve that follows the contour of the lid. So a notch is inevitable, and the procedure was difficult because it would involve a lot of tissue crushing, etc. One modification that came about 9 years later was by Beard, who started using subconjunctival closure. He used buried suture in the conjunctiva to close it. The initial procedure did not use sutures. That also resulted in granuloma formation and a lot of inflammation and secondary intention healing, thus maximizing scarring. Puterman started using clamp for Fasanella Servat procedure, and then he also described the use of a clamp for mullerectomy. That was the modification in 1972. So you can see that from 1961 to 75, there were a lot of modifications that happened in Fasanella Servat procedure, including back to sutureless by Loring, sutureless surgery. But people found that if you are not suturing, then there is a higher chance of having pyogenic granuloma, secondary intention healing, and if at all that patient needed a second surgery, then that would be, even from the anterior approach, become difficult because of fibrosis. The latest modification that we use was in 1983. After that, unfortunately, no modification has been done on Fasanella Servat procedure. That doesn't mean that the final modification is so ideal that no modification could be performed. It is just that people have lost interest in this procedure. That's what I feel, because nobody talks about it much. Although it is a good procedure, it is not a bad procedure at all. In a given situation, it works very well. The modification that Dr. Betheria and Grover did was the use of sutures, not hemostats, not the use of clamps, and this makes it very standardized. So the procedure that I would talk about would be Betheria Grover modification that was published in BJO. That is what we follow because we are all his trainees. Now, it was initially described, it was called levator resection for minimal ptosis. So when Fasanella and Servat described it, they thought that they were actually resecting the levator, because levator is attached to the anterior surface and the upper edge of the tarsus, and by excising the tarsus, they thought they were indirectly excising levator. On histopathology, subsequently, Beard and later Puterman found that levator was not involved at all. It was not a part of the tissue that was resected. Beckman finally established that it was only the tarsus and the tarsal conjunctiva that was resected, and in some patients, about 25% of patients, there were some fibers of Muller's muscle. So finally, the name that has settled down to Fasanella Servat procedure is tarsoconjunctivo-mullerectomy. But then mullerectomy is not always a part of the procedure. It depends on the insertion of the Mullers and the amount of Mullers that is captured within the tissue to be excised. Standard indications: 2 millimeter ptosis and more than 10 millimeter levator action. If you want to perform in a patient with 2.5 millimeter ptosis, well, that is possible. I'll explain to you how we go about that. But 2 millimeter ptosis, more than 10 millimeter levator action makes it highly standardized. The most important advantage of Fasanella Servat procedure is its predictability. You get exactly what you measure. There is no short changing at all. In levator resection, there is some amount of unpredictability. In molarectomy, there may be some amount of unpredictability. But in Fasanella Servat, you get exactly what you measure. That is a major advantage in ptosis surgery. That is the reason why some surgeons prefer it. And how much do you excise? The standard thumb rule is that for every millimeter of ptosis, you excise 2 millimeter of the tarsus and tarsal conjunctiva. In fact, it is 4 millimeter of tissue that is excised, because if this is the folded tarsus and you are excising 2 millimeter of the tarsus and tarsal conjunctiva, on the other side would be palpebral conjunctiva as well, which is of equal amount. So you are actually excising the double the amount of tarsus and tarsal conjunctiva that you are excising. You are excising an equal amount of palpebral conjunctiva as well. So the rule anyway is 2 millimeter resection of the tarsus for every millimeter of ptosis. That is how you measure. Now, what are the prerequisites? You should have adequate tarsal height. What does it mean? That means for a 2 millimeter ptosis, you should have at least 8 millimeter of vertical tarsal height. Why is that required? Because at least 4 millimeter of the intact tarsus is required to maintain the stability of the eyelid, not to cause ectropion, entropion and standoff, and also to provide adequate meibomian gland function. In meibography, which has been reported following Fasanella Servat procedure, it was found that the meibomian glands in the residual tarsus were functioning normally, and the dry eye is not a common complication, especially since the surgery is done in young individuals. Dry eye really is not a common complication. A thesis that was done at RP Center, which ultimately did not get published, showed very clearly that dry eye was not a complication. Since I was a part of the thesis, I can vouch for the results that we had about 120 patients in that thesis, and none of the patients developed dry eye over and above what they already had. So it was not a problem. Now, how is the surgery done? First is to evert the eyelid. This is how it is everted, and you pass a set of 3 sutures through the everted edge of the tarsus. Then you pass a second set of sutures from the fornix, superior fornix, coming just short of the lid margin. Then you measure out the amount of resection right in the pupillary axis where the central suture is situated. If you have decided to excise 4 millimeter, you measure that out right in the middle of the tarsus in relationship to the pupillary axis. Then you excise that amount of tarsus and tarsal conjunctiva. I'll show all this in a video as well. Then you suture this. This conjunctival suturing is actually subconjunctival. It is not an exposed suture. It is a completely buried suture, and the knots are exteriorized. And the suture material that is used for this purpose is plain catgut, which is soaked in a bowl of saline to make it supple. About 5 to 7 minutes you soak it, and then you use it so that it's a supple suture. It does not erode the cornea at all. It does not cause corneal epithelial problems. If you ever feel that your suture is not completely buried and part of it may be exposed, there's a loop of suture that is exposed which may become inevitable sometimes, then you simply use a bandage contact lens for a week. After that, you simply pull out the catgut suture because the knots are on the outside. You have to cut this knot and pull it off if the catgut is not completely absorbed. Absorption of catgut sometimes is variable. It does not always happen in 5 to 7 days. Even if you use fast gut, sometimes it remains in the tissue for about 7 to 10 days. So if you find that there is any corneal erosion or epithelial issue, you can remove the suture. So I'll go to the video. Right, the surgery is performed under frontal block in cooperative patients. Lid is everted like this, and the first suture is placed in the pupillary axis, and that is through the everted eyelid. This is a 4-0 silk that we are passing through the everted edge of the tarsus. That clamp is no longer used. You can see that is how it was earlier performed, but we no longer use it. The second suture is at the junction of medial 2/3 and lateral 1/3 of the residual lateral half of the lid. And the third suture is at the junction of medial 1/3 and lateral 2/3 at the medial half of the lid. Once these 3 sutures are passed, you ask the patient to look down and pass a suture starting from the superior fornix, exiting just short of the eyelid margin. I will show you the purpose of the second set of sutures a little later. Similarly, lateral and medial. And you pass the lateral suture, you should be very careful because you don't want to pass it through the palpebral lobe of the lacrimal gland. You should put it aside and pass the suture, otherwise there will be immediate brisk bleeding. Similarly, a medial suture is passed. Dr. Grover is watching keenly because it's his modification along with Dr. Betheria that I am showing. The lid is laid flat on a spatula and the amount of excision is marked in the center. The central suture corresponds to the pupillary axis. And you mark it either with a marking pen or you can use a bipolar, and you anemize the area of excision with a bipolar RF electrode so that it becomes relatively bloodless. Now, as you see, when I am going medially and laterally, I am tapering this incision to suit the match the contour of the eyelid. That will actually help you in getting a very nice lid contour. You don't excise 4 mm in the extreme medial and lateral side, you actually taper the contour. Then you make a very thin conjunctivo-tarsal groove and keep on going deeper. Definitely you can use scissors and Bart-Parker knife at this stage, but using electrosurgical devices, make sure that you see everything that you cut. So it's very controlled surgery. You can see a gape there that indicates that we have gone full thickness through the tarsus. Slow and predictable movements. And then you lift the lid off the spatula and excise. So now you note that we have excised 4 mm of the tarsus and tarsal conjunctiva, but folded on the other side would be 4 mm of palpebral conjunctiva. So it's actually 8 mm of tissue that you are excising. That is the reason why there is a chance of having entropion if you select a wrong patient, or lash ptosis if you select a wrong patient. Now once you have excised it, that is the reason why you put the second set of sutures. You hold them both together and your posterior edge of the conjunctiva comes right into view. Otherwise, if you don't pass the second set of sutures, the posterior edge of the conjunctiva would be retracted close to the fornix, and for every suture bite you will be digging into the fornix. And the patient, these surgeries can be done definitely under topical anesthesia, which a little bit of paracaine injected subconjunctivally. So patients may become uncooperative if you keep digging into the fornix, right? So this is, see how easy it becomes for you to pass the suture. This is a plain catgut suture that is run across, and finally it is knotted on the other side of the wound. It is exteriorized from the skin and knotted on the other side of the wound. Why do we knot it on the other side of the wound? Because if at all catgut remains unpredictably long in the tissue and you want to remove it, and if there is corneal epithelial erosion, etc., you simply cut the knot from one side and pull it off. So it's easy. Otherwise, you'll have to evert the lid to remove the suture, which means that you're disturbing the wound completely. That is the idea why we exteriorize the knot. It works very well. As I said, it's a very predictable surgery. The most important advantage of Fasanella Servat procedure is that it is highly predictable. You measure exactly what we get. Like this patient with mild ptosis, we can exactly get what we predicted. This is again a patient with mild ptosis. In the left eye, you can see that her lid crease height has got normalized. So it was a misconception that Fasanella Servat procedure cannot address the eyelid crease height. You can see her eyelid crease height, which was higher on the other side, has become totally normalized following this surgery. This was the lid crease height, margin crease distance. It's got symmetrical with the other eye. And again a patient here where the lid crease height was high and it's got normalized, matching with the other eye with Fasanella Servat procedure. So it is easily possible to match the lid crease height without even touching the lid crease or the dynamics of the levator aponeurosis insertion into the skin. When not to do this procedure, whenever a patient has lash ptosis. Lashes are supposed to point upward and forward. If the lashes are pointing horizontally like this, or if they're already pointing down like this, then if you do a posterior approach surgery, then you would cause some amount of diffraction because lashes will come right in the visual axis. So you prefer not to do this surgery. Even in patients who have a horizontal lash, I would prefer to do an anterior approach so that the lash ptosis does not occur. Now complications as usual for ptosis surgery, under or overcorrection, but that is very, very minimal with Fasanella Servat. Poor contour could be a problem if you don't follow the contour of the eyelid or if you use hemostats. Corneal epithelial erosion used to be a common problem, but that can be minimized by using sutures which are completely buried. You can use glue also, but when I shifted to glue, that is TCL glue, I found that there is undercorrection for some reason. I don't know what was the reason. So I've shifted back to the sutures. Dry eye is not a problem if you leave at least 4 millimeter of the tarsus. Entropion and elastosis can be minimized by selecting patients who are appropriate for this procedure. Thank you so much.
Thank you, Dr. Santosh. It was a nice talk, and I think we are open for a brief question answer session for 2 minutes. I'll invite Dr. Grover to come up on the dais, please. So, yeah.
He does it better than the descriptions. Beautifully done, sir, and very educated. It is a very predictable procedure, as you said, but provided you have fulfilled the
So they're recording if you want to use the mic.
So the great advantage is the predictability of the procedure, where you fulfill the basic preconditions of levator action exceeding 10 millimeters and ptosis not exceeding 2 millimeters. And I sometimes, Indian tarsi are not more than 8 millimeters, sometimes 7 also. So in those I may modify to reduce the maximum. Generally I confine my maximum resection to 3 millimeters so that I have enough tarsus left for stability. And dry eye has never been a problem. I've not yet seen cases 30 years back operated, 20 years back operated. Anybody who's has had a clinically significant dry eye who's had a past Fasanella Servat surgery, not a single patient so far. So I think that concern is misplaced, and stability and contour have not been a problem. So it's
In a case with shorter tarsus, I augment it by plicating the levator posteriorly. I simply take two horizontal mattress stitches in the levator aponeurosis from the posterior approach. That helps if you have a shorter tarsus.
We can also use nylon sutures, same way, just pull it out after a week.
Sure,
I
but
find that
yeah,
easy
buried
to do.
sutures, if you use nylon, that's fine.
Yeah.
So 6-0 nylon again taken out from two sides. I often use that for some of the procedures.
But Santosh, do we get 6 catgut nowadays?
No.
Plain catgut.
5O catgut is available.
6-0 I have not been able to
It
So I
was
use
there
nylon.
once. Now it's.
Chromic
one
is
more.
available, but plain is 5O is available.
Sir, I have a question to you. So this is basically when it was started, it was tarso-conjunctival. So what was the mechanism of the ptosis correction? Is it a LPS plication? Or what was the main
So
mechanism?
the
Because
histopathology showed that you often get a bit of levator also, but tarso-conjunctivomullarectomy is the basic name, but sometimes you do have some bit of resection of levator also taking place. But we would largely say that it is intended to be a tarso-conjunctivomullarectomy. You are doing a Muller's resection, and you're shortening conjunctiva and you're shortening tarsus. So
Vertical shortening of the eyelid with, because when you do this and suture the conjunctiva back, you cause unintended plication of the levator.
exactly.
Right? That is the reason possibly when I shifted to sutureless surgery. Sutureless surgery is very exciting. Topical anesthesia, sutureless surgery. Everybody wants to do it. So in ptosis, topical is possible. Then I started getting undercorrection.
but there are descriptions, Loring's description, others descriptions, which are sutureless. They claim good results, but I haven't ever dared
Absolutely.
to do it.
I never got good results with sutureless.
Or there are those mullerectomies with single stitch technique and so
In
on.
fact, the first case of sutureless I did, I had to go back at the end of 1 week to suture it, and then absolutely the patient was fine.
Thanks.